cancer awareness, next on Call with the Prairie Doc.
Good evening and welcome to On Call with the Prairie Doc. Dr. Holm is off tonight. I'm Lindsey Meyers, former host of this program, and it's great to be back with you for an evening. In the United States, breast cancer is the second most common cancer in women after skin cancer. Each year there are about 230,000 new cases in women. With all of the walks, runs, and fundraisers that happen around breast cancer, just like the Avera race, which will bring thousands of people together this Saturday, it's hard to not notice the pink ribbons around us signifying the survivors. But beyond all of the events are the personal stories of people who are touched by breast cancer. The uncertainty of a diagnosis or the joy of being cancer-free are experienced by not only the patients, but their friends and families as well. Breast cancer touches almost all of us in some way. Before we introduce our guest tonight, let's take a look at this week's Prairie Doc quiz question. It's a multiple choice this week. Among women who have health insurance, 72% have had a mammogram in the last 2 years. Among those who do not have insurance, the rate is A, 22%, B, 39%, C, 44%, or D, 53%. Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of Dr. Holm's essays originally written for this show comes with a wonderful accompanying photograph by Dr. Judith Peterson. We'll announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answers in. We answer your medical questions about breast cancer as they're called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225 or send us an email to the address on the screen. To begin our program tonight, we have Dr. Julie Reiland with Avera Medical Group Comprehensive Breast Care. And Julie's sister is with us, Jill Machi, who's a breast cancer survivor. Thank you both for being here tonight.
Thanks for having us.
Well, we're excited to have you with us, Jill, and we understand you're a survivor and your sister works in this field. So tell me about when you were diagnosed and what happened.
Sure. Interestingly enough, 5 years ago this week, I was diagnosed with invasive lobular carcinoma. I was 48, had no family history of it. My first phone call was to her because I didn't want to call my husband unless I knew what was going on. So we chatted, and within 3 weeks I was scheduled for bilateral mastectomy, axillary dissection, followed by chemotherapy, radiation, reconstruction, physical therapy, and the whole shebang.
Dr. Reiland, what was that phone call like for you working in this field?
Well, you know, I think there's something where you feel like if I'm a breast surgeon, then somehow the rest of my family will be protected from this. I can, by doing this and taking care of other people, I can protect my own family. So that was kind of a tough call. But, you know, at the same time, it was like, I know how to do this. And so I'll call you back. I'll find it. I know people. And so she lives in Milwaukee, and I knew someone who lived in Milwaukee who was actually connected, and I started making phone calls, and I got her lined up with the people I thought were going to be the best for her.
Wow. And you really do have to be an advocate when you're going through a cancer journey. Wouldn't you agree, Jill?
Absolutely. For me, the road was pretty well paved. I mean, she called me back within 4 hours and said, here's your surgeon, here's an option for a plastic surgeon. And I was like, well, Julie, what am I going to look like after a mastectomy? I really didn't know. I don't know that a lot of women really do know. And she said, give me 4 hours, I'll send you a PowerPoint. And she did. She sent me a PowerPoint of all of her small-breasted patients who'd had double mastectomies, and I was like, okay, that's what I'm going to look like. All right, let's giddy up and go.
Wow, you have a great attitude going through this.
It is all about attitude. It is. I mean, I finished treatment, and 2 months later I was training for a triathlon just to show my body who was in charge. So it's just really all about, you know, taking care of yourself and sticking with it and persevering through it.
So 5 years, I mean, that's wonderful news.
It is wonderful.
So is it frightening when you go in for your checkups still for you, or do you just feel empowered that you made the right choices and things are going well?
I feel I made the right choices. I definitely would not change anything I did. I didn't have a lot of options. I'm a small-breasted woman, so it was pretty mandatory that I have a double mastectomy. I didn't have a lot of choices for my health. And when you go in, there's always that, are they going to find anything? And for the first 2 years, you know, if my knuckle hurt, I'm like, oh my God, I have cancer in my knuckle. And my oncologist was awesome. She's like, "You're good, Jill. All is good. Everything's fine." And now I think I'm healthy. I have a very healthy lifestyle. I feel really, really positive about my long-term outcome and survival rate.
So Dr. Reiland, your sister had a great champion in you to help her pick a great surgeon. So what do you recommend to patients when they're looking for that care team when they do have a diagnosis like she did?
I think word of mouth is really important. I think if a woman, and usually in my experience, that once you get breast cancer diagnosis, other women with breast cancer call you immediately, and people you never knew had breast cancer will call and say, "I had it, and this is what you need to do." Be careful, because some of those women are, this is what I did, therefore this is what you need to do. Everybody's different, and everybody has to have a different treatment. But I think if there's something that you feel uncomfortable about, or if you're just like, "Yeah, I think I want to get a second opinion," it's always good to say, "I need a second opinion." I always tell my patients, if someone tells you that that's not a good idea, you run from their office, because we should all be okay with somebody, any of our patients, needing to have reassurance from someone else besides us. And it's not about us, it's about them and being comfortable. So if you see someone and you're like, "I think I better go check something out," listen to your inner tuition, because that's actually very, very accurate. So many of my patients had that great intuition that made them do the things that they did, and they made good choices. So listen to that.
So you two taught a cooking class last night together.
Yes,
so
we did.
Is prevention part of your story then, Jill,
Absolutely.
and being able to change diet and exercise and whatever you can?
I have always been very healthy. I have always been pretty active because I wanted to. Now I am because I need to. I try to do mostly plant-based diet. I really try to avoid sugar. I challenge myself a lot with my physical activity. Last year I biked 1,000 miles. This year I'm going to bike 1,500. Now they've said it on TV, I have to do it, right? But it's to me, it's mandatory. I have to eat healthy. I have to maintain a weight. I have to keep the fat off. I have to keep the sugars out. It's just not, it's mandatory for me. It's not a choice.
And Dr. Reiland, has this changed how you approach your patients going through this journey with your sister?
Absolutely. She told me things about her recovery and things about her journey that my patients probably are too shy to tell me. And so then I was able to open up to my patients and say, "You know, how is nipple sensation for you?" Because she shared.
Because you don't have them anymore, so how is it?
No, so I was like, "Oh my gosh, Jill, I've always wondered, but I never knew." Because for some women it's really important, for other women it's not so important. Sure. And she helped me by telling me what her experience was. I thought, I have to start asking my patients this, because she needed to have that conversation. So there were so many things that she went through that I just didn't think about it as a provider, but now I have a sister who doesn't have any problems telling me anything.
Well, you two are an amazing duo, and we're so excited to have you, and congratulations on that important anniversary that you're celebrating, and thank you for being here, and we'll have more with you, Dr. Reiland, in just a minute.
Thanks.
We'll be back after this.
My cousin Veronica was diagnosed with breast cancer when she was 38, and she's just a year older than I am. In my family, there are a total of 6 women who've been diagnosed with breast cancer. 4 of those women were under the age of 50 when they were diagnosed. The first person diagnosed was my Aunt Martha. She was 39 years old, and I was 19 years old. Then when another aunt became diagnosed, and then another one, it started becoming way too real. I had the conversation about breast cancer before my son was born, but once my kids were born, everything just amplified, I guess you could say. All of a sudden, now I have children to think of. I have children I want to be there for. Finding out that Veronica had cancer and us both having young children, it also made me very aware of how I could possibly be the next person in my family, to be honest. I started talking to my doctor about it when they were asking me about family history, and they found out how many aunts I have with breast cancer. Knowing my family history of breast cancer helps me manage my own risk. It can be hard to start this conversation with your family, particularly if they're private. If you have a family member who has a gift about talking to others, maybe you can use them to help relay the information to you. My family history with breast cancer doesn't predict my future, but it does help me make more informed decisions about my future.
Joining Julie and I in the studio now to help answer your questions tonight is Dr. Amy Krie with Avera Medical Group Oncology and Hematology in Sioux Falls. Thank you, Dr. Krie, for being here with us also. So Dr. Krie, tell me about the prevalence of breast cancer. It seems like it's almost everywhere with the races and the pink ribbons, but is it more prevalent in South Dakota, or what do you see as far as rates go?
You know, we see the prevalence in South Dakota is really no different than any other state in the Midwest. Breast cancer is the most common invasive cancer diagnosed in women in South Dakota, and on average per year we expect somewhere between 600 and 700 women to be diagnosed with breast cancer in our state.
It's such a scary diagnosis that we hear of so often, but survivability is very good, is it not? Right.
So we tell women that for early stage breast cancers, the majority of women are going to have 90 to 95% survivals now. So for most women coming through our clinics and seeing Julie and I, their outcomes are going to be very, very good. There are patients who present with more aggressive cancers and more advanced cancers, and that's when we really like to get our research teams involved, and because we know there is a chance that those women could have recurrences, and we want to do everything we can do for them up front.
And Dr. Reiland, is it mostly those more invasive cancers that you see as a surgeon then?
Well, a lot of times I'm the gatekeeper. So once a woman is diagnosed with a lump, then she comes to see us, or she's had a biopsy, and then she has, then we talk about her options. But today, there's so many options that they can have for their initial treatment. It's not always going to be surgery. And it's my job to really look at that woman and say, your tumor is the type that you would actually benefit from chemotherapy first. I need to send you to Dr. Krie. But this is also after we've had our multidisciplinary conference and we've talked about that woman as a group. So then when I meet her, I've had 15 other docs and we've all had a wonderful discussion about that individual, and then I can say, okay, this is what we think is your best path, and then we get you to the right people. So today it's not surgery first and then do chemo and then radiation. It's actually, let's figure out what that tumor biology is, what makes that tumor aggressive or not aggressive, and then make decisions based on that.
Wow, tell me more about that team. I mean, you don't hear that very often, that you have 15 doctors that are looking at your case. Is that really the case with patients that come through?
So it is. So we actually still present every case of breast cancer at Avera, and then we have a lot of different outreach sites. So sometimes if a surgeon has a complicated case in a smaller community, they'll review that case with our team as well. And sometimes we'll make recommendations and they'll have to come to Sioux Falls for part of the treatment, but we do also open that conference up for people who have other questions. There is a lot. What we'll present is sort of their pathology. So our pathologists who do a lot of breast cancer will look at their pathology and give opinions on something we call grade. So how aggressive does it look under the microscope? There's certain markers. I'm sure women have heard of estrogen receptor, progesterone receptor. We'll talk about what those markers are for an individual woman, and then we'll often present all of her breast imaging. So her mammograms, if she's had an ultrasound, if she's had an MRI. And then the team comes to a consensus as to what is the best approach for that patient. Is it surgery up front? Is this a simple, straightforward breast conservation followed by radiation therapy, or is this something that needs to be more involved?
And you have a multidisciplinary team of many different perspectives coming together. Are there disagreements, and how do you work those out sometimes?
Wonderful disagreements, because well, you know, if you all agree, then everybody gets kind of laid back, and they're not. Everybody, I'm so proud of our group because everyone's so passionate about how they see their job, and sometimes the radiologists are very, very passionate about what, and I'm just as passionate about what I should do, and so it gets never unfriendly, but very passionate. I guess that's a good word.
I think the best thing about the conference for me that I experienced was sort of life through someone else's eyes. So I know what I do, and I know what I do very well, and I know how to give chemo and pills, and I know all about that. But looking to see maybe what is Dr. Reiland thinking when she approaches a patient, or what is the radiation oncologist thinking? What do they need to know before I start chemo and shrink the tumor? That's really going to affect how they later on treat that patient. So probably the best aspect of a comprehensive team like we have is that you also learn what's going to be important for your partners to know, so things don't get missed. And that way we're not, Julie knows a lot about what I do, so by the time that the patient has seen me, Julie's sort of gotten all the pieces of the puzzle that I need to do to make decisions, and I hope vice versa. But that perspective is probably one of the best outcomes of a comprehensive program.
And you have a new genomics team that you're working with at Avera. When do they get brought into that conversation then for patients?
So Dr. Leland Jones and his team joined us now 2 or 3 years ago. I don't know, we're all getting older. But so where genomics comes in very commonly is for patients who have stage 4 breast cancer. And maybe I should explain what genomics is first, because that's a buzzword that I think people maybe don't fully understand. So genomics is sort of the next level of looking at a cancer. So grade, HER2 status, these are things that are standardly done. But in what the future holds and what we're doing as part of our genomics research is we're actually looking at the genetic changes within a tumor. And so some of those genetic changes will help us to know before we give a treatment that treatment will or won't work, or at least give us a strong suggestion. Or some of those genetic changes may tell us that a certain treatment or a certain research is going to be better for that patient to enroll on a certain clinical trial because that drug would work for the genetic changes we're seeing in that patient. So it's the next dive down in getting very specific about how we treat patients. We've known for a long time that not every chemo works for every patient, that you may have breast cancer that responds to a drug called Taxol, and you may have breast cancer and it doesn't. And so what the genomics are doing is allowing us to predict ahead of time the best combination of treatments, and also using a lot more targeted drugs so we can hopefully minimize the side effects that patients experience, but yet keep that tumor under good control.
Wow. Will that be standard of care someday, do you think, with the way that medicine's moving?
It really will be. It really will be.
That's exciting.
And what's really exciting is I speak about this to around the country, and when I tell people what we're doing at Avera in Sioux Falls, nobody can believe it. They say, "What? You're doing that in Sioux Falls?" I say, "Yeah, we are." "Well, we don't think we're going to be able to do that for the next 5 years. How did you manage this?" And we just have a great combination of some really talented people that came together, and it was the perfect thing. And so we are doing things that no one else in the country is doing right now.
And Dr. Reiland, you're traveling all over the world to talk about intraoperative radiation therapy that you offer. Tell me a little bit about that, because we're going to see more from one of your patients in a couple minutes.
Well, the standard after a woman has breast conservation, which, let me just say first, whether you remove your breast and do a mastectomy or whether you have a lumpectomy and radiation, your survival will be the same. So I always tell my patients, removing your breast does not guarantee you will live longer. Okay, so why not keep the breasts? And one of the problems that we have in South Dakota is that so many of our women are in the rural areas, and getting to radiation, which is typically 6 weeks, 5 days a week. That's a really long time, and a lot of my patients were choosing mastectomy because they wanted to avoid radiation. So intraoperative radiation has been around for since 1998, and we now have studies that show for patients who have better behaved or lower grade tumors that we can give them a single dose of radiation in the operating room and they don't need any other radiation. So we've eliminated that 6 weeks. And we are one of 10 places in the United States that offer this, and most of it is being done in Europe. So we are early adopters of another new technology, genomics, intraoperative radiation. We do a lot of really, really novel and advanced things.
And I'm going to talk about all these things tomorrow at the conference too.
Oh, yes.
I have great slides.
And what conference is that?
So there's a conference tomorrow for survivors at Avera. I don't know if it's too late to register or not. But,
no, it's not.
But all day, actually, it's different breast cancer topics. And it's geared not towards physicians, but it's actually geared towards patients. So I'll be the 4 o'clock presentation, and we're going to go over a lot of these new things that we're doing at Avera, so that'll be exciting. But just one other point I wanted to make on your study was that that's one of the reasons I think it's still important to find cancers early.
Oh,
so
yes.
there's been a lot of debate about mammogram. Do you need one every year? And there's a lot of debate out there, and I think right now the guidelines are left to, a woman needs to discuss things with her physician. But one thing that I worry about is that if cancers are detected at later stages when they're larger, even though that might not necessarily change the patient's survival, it is probably going to change the options they have in terms of treatment with you, particularly.
Right. Very true.
Because the intraoperative radiation therapy, there's a size limit. So we really do like to catch these cancers when they're smaller, when a woman's options are going to be, more. She's going to have more choices.
Wow, there's so much to be hopeful for right now with these new treatment
Oh, yeah.
options. And we're going to have more with you in just a minute. In the past, women from rural areas would sometimes opt for a total mastectomy rather than drive for radiation treatment due to the amount of travel involved. Now a treatment called intraoperative radiation therapy, which we were just discussing, is allowing women like Terry Pearman to get a dose of radiation during surgery, shortening the amount of radiation treatments needed. Here's Terry's story.
It was a routine mammogram, actually not quite routine. My doctor in Eagle Butte had been bugging me every time I would go in for labs to get medication refilled to get my mammogram and stuff done. And so finally about the second or third time I said, okay, to make you be quiet, I will go have it done. So then I scheduled it, got in. That was probably in early February.
Terry was diagnosed with a very well-behaved breast cancer. It was small, and it certainly was small enough that we were not very concerned about it having spread. So she was an excellent candidate she has a great prognosis, a very, very high chance that she will never be bothered with breast cancer again once her treatments are completed. I do believe that intraoperative radiation with electrons is going to be the best treatment that we have for women for breast cancer. So 40 to 60 is where we're going to want to give those women a boost of radiation in the operating room and then also give them additional radiation to the whole breast after their surgery, especially for those women who have stage 1 and stage 2 disease. So the smaller tumors and the women in their 60s, they're perfect for this, and we're actually going to single dose. So now they'll get 1 dose of radiation in the operating room, we'll do a breast lift, we'll make them look nice when we're done, and they're done. Then all they have to do is talk to the medical oncologist. Do they need a pill? Do they need chemo? But their surgery and radiation will be completed in 1 day.
But that day that they told me I had a choice between Rapid City, Bismarck, North Dakota, Sioux Falls, in rare cases, Mayo Clinic in Minneapolis, and were kind of pushing me to possibly give them an answer that day, and I couldn't do it. The most information I found was in the Sioux Falls website. Downloaded a bunch of that was able to describe everything that I was possibly going through, that I was feeling, and knew it was okay to be feeling all of that. But it was also enough information that I could pass it on to my husband and my son, so they knew what I was going through and they were knowing what to expect.
And for her, she actually is very clever woman. She really researched us. She found us online. There were about 7 facilities that she looked into and felt that we had the most to offer for her, so she came here. So we definitely, what we'll do when she comes to see us is we'll get her mammograms and see me on the same day. She'll also see her medical oncologist. So every time they come, we do everything in that day. And sometimes it's a day or 2, and they just have to spend the night. But to them, it's worth it because now they're done, and now they go home for 6 months.
I have absolutely no regrets. If I could have everybody I know that is battling breast cancer come here, they would be so much better, I believe.
The best part about my job is my patients when they come back, and 6 months down the road, they're done with their treatments. They feel good. Their breasts look nice. They say, "Boy, you can't even tell that I had surgery because they look so good." To me, that's the most rewarding part.
This is your show, and your questions are key to our discussion. Call in your questions about breast cancer to 1-888-376-6225 or send us an email to ask@prairiedoc.org. Well, that was a really interesting segment, and we got to come into surgery with you for that. So, but oftentimes with IORT, you also do a procedure called oncoplasty. So tell me what oncoplasty is.
Oncoplastic surgery is where we actually remove the cancer. That's number one. We have to remove the cancer and do that very well. And the second part is we take out the cancer through plastic surgery incisions, the same ones that a woman would have if she wanted to have a breast lift or a breast reduction. And so since I have to go in and take out the breast cancer anyway, why don't I do it through these sorts of incisions, and then after I remove the cancer, I can reshape that breast, close up the breast again, and now you have a breast that is more firm and somewhat uplifted and has a much better appearance than perhaps even before your surgery.
I've actually talked to some of your patients who have said that it's better afterwards, which was really surprising to me. You don't always hear that,
Right.
especially when women have gone through a breast cancer journey like that.
Oncoplastic surgery is really having a hard time getting a foothold. There are very few surgeons in the country who actually do this. Most surgeons, when you have a breast cancer, they make an incision right over the tumor and they go down into the tissue and they take it out and then they close the skin. And after everything heals, you get a dent. And then after radiation, that caves in and then you have puckers and it's very disfiguring. So oncoplastic surgery avoids that in a lot of many really great ways. And it's just a wonderful opportunity. It's now starting to gain some speed, and I teach that to other surgeons around the country as well, which is really exciting because I can only operate on so many people, but if I can teach someone else how to do this, then I have affected a lot more women.
Dr. Krie, you see these women right away while they're going through kind of this decision-making time. So do you have women who are struggling with what to do, and how do you guide them through that?
Sure. So Julie and I think both, Julie probably more than I, kind of partake in this discussion, and I think it's a choice, it's a hard choice. Take the hard path or the sort of hard path, right? There's no good option. So, when women are faced with a diagnosis of breast cancer, kind of the first decision that they often come to is what surgery to have. And I think sometimes out of fear more than anything, women tend to just say, well, get it off, right? Because it's got cancer in it, get it out of me. And what we know is for mastectomy, there is a little bit higher chance of complications, particularly if a woman needs to get plastic surgery. And so there are some women who have to have mastectomies. So there are some women who inherit genetic changes. So they have strong family histories of cancer. Angelina Jolie gene, I think, is probably the most well-known, but there are others. And those women have a 30% chance of getting another cancer in the next 10 to 15 years. So for those women, mastectomies make sense. For other women, it's a matter of we can't image them very well. Or maybe their tumor is larger, but they have a very small breast size. So no matter how good Julie is, there's no way that we can kind of fix the fact that that breast would be a lot smaller. But that's really kind of the minority of women. So the majority of women we see have small, not aggressive cancers. They're over the age of 50. They do not have strong family histories. And there's really no need, I think, in most circumstances to undergo a mastectomy when a smaller surgery is going to give them equal outcomes. And another thing that people, I think, that's just cancer in the breast. The real issue is preventing cancer from coming back in the body. So removing both your breasts does not change the chance of breast cancer showing up in your lung or liver. It also doesn't get you out of, if we need to do chemotherapy, we need to do chemotherapy. It doesn't matter whether you do a lumpectomy or mastectomy. That's not going to change my decision on the chemo or the pill treatments. For me, it doesn't matter which breast surgery you do. Those are going to be the same because those are based on your cancer's biology and wanting to prevent the cancer from spreading to the distant organs.
So you can do these conservation therapies and still have the same outcome.
Yes, absolutely. And we've shown it for the past 40 years. It hasn't changed.
You mentioned Angelina Jolie, and you know that got a lot of press this year. So I mean that seems very radical. I mean, for a woman to have mastectomy like that. So tell me a little bit about that genetic piece. That
So we'll just talk about BRCA because this is a hour-long conversation all on its own, and I talk a lot, obviously. So BRCA, I think of it as sort of the mechanics of your DNA or your genetic code. So as we age and our cells divide, that genetic code has to divide too. And mistakes happen during those divisions. If you have a problem with your BRCA gene or your BRCA gene is mutated, like Angelina Jolie's was, then your mechanic is sort of out to lunch. So you get a lot of genetic changes in yourself very early on, and that predisposes to very early age onset of aggressive types of breast cancers and ovarian cancers. So if I had the BRCA gene, and I just found out today, if I was BRCA1 positive, I would know that my chance of getting breast cancer in my lifetime was probably around 80%. And my chance of getting ovarian cancer is probably, I think the latest statistics are around 60%.
wow.
So those are much higher than anyone else in the population. You know, everyone else is down at 11, 12%. So for those women, it's sort of when they're gonna get cancer. And still, even with the gene, not all of our patients opt to have mastectomies. Some choose aggressive screening protocols, but that is a step that some women certainly do take, and it's understandable. I think the key that Dr. Reiland and I always want people to know, though, is that the vast majority of our patients don't have these genetic changes. So the majority of the patients coming into our clinic have no family history at all, because one of the things I hate to hear is, well, I didn't get mammograms simply because there's no breast cancer in my family. And for most of our patients, there isn't.
Wow.
So the women who have these strong family histories need to be aware. They need to talk to their doctors about seeing Dr. Reiland or seeing a geneticist. But women who don't have family histories can still get breast cancer, and that's a really key message, I think.
Well, when my patients say, I didn't think I could get breast cancer, it's not in my family, I say, welcome to 85%. 85% of women who get breast cancer do not have a family history. Only 10 to 15% of women have a genetic mutation that predisposes them to breast cancer. So the majority of women need to have screening and would benefit from that, because there's not this family that's going on. They're not in increased surveillance because of a family history. They're just out there being women, and that's why we think it's so important that mammograms are done on a regular basis for everyone.
I know women may have, I know one thing I wanted to talk about tonight was, you know, women may have a lot of questions about mammograms because I think there's been a lot of press, right? Mm-hmm. So 1 year versus 2 years versus which one should we do? And, you know, very, very bright people have huge debates about the frequency of doing mammograms.
Sure.
And the issues are when you're younger, you know, mammograms are a little bit harder to read. And when you're older, you tend to get, you know, somewhat slower growing cancers, but those rules don't apply across the board. And I think we can debate that. What I actually see is a very large number of patients, unfortunately, who haven't had a mammogram for 5 years, 6 years. So the debate about yearly versus every other year sometimes I think doesn't apply, because we still have so much of our population that either have never had one or certainly haven't had one in the last 2 to 5 years.
So what age should women get mammograms then? Because that's very controversial right now.
Yeah, I still believe in the age of 40. That's what I did. So I do yearly mammograms at the age of 40. And my reasoning to some degree, because I have no family history, but my reasoning is I think I'm willing to put myself through the risk if I have a false alarm, and I've had false alarms. I've been called back. Little Miss Dr. Reiland here has to order my follow-up imaging. And it is very anxiety provoking. And when they're making these screening recommendations, you know, one of the things they look at is, you know, you have a lot of anxiety when you get called back that your mammogram might not quite be normal and we want to take a second look. So I was already, you know, planning who's going to raise the kids. I got a leave list for my husband, and all I had was a little bit of an abnormality that needed a second look. But that's the issue, you know. But what I say is young women do tend to get, on average, those faster growing cancers, those more aggressive cancers. And if I can pick those up as an oncologist early, in that kind of cancer that's aggressive, I have such better odds of curing that patient, and that's why I sort of do my mammograms more frequently.
And some women do have difficulty with mammograms. They might have dense breasts, and we have a 40-year-old from Rapid City who is wondering about mammograms for women with dense breasts. What do you recommend there?
Well, the 3D mammogram is the new one that's out, and that's certainly been shown to be much better at looking at dense breast tissue. But even those are really difficult sometimes, and so at Avera we actually have a new thing called a contrast-enhanced spectral mammography, and I call it a mammogram on steroids. So what you do is, it's like an MRI, which is a very complex test where you have to lay in a tube with your arms over your head for an hour and they take 4,000 pictures. Contrast-enhanced spectral mammography is a mammogram with an IV. They inject you with the same kind of dye that you would use for an MRI, and then they take a mammogram again. Now, cancer cells will increase or take up this dye much faster than normal cells. And so when we have someone who has very dense breasts, meaning that there's all white in their breast tissue, cancer is white and breasts are white, you can't see the cancers. But when we do contrast enhanced, only the tissue that has more activity is going to turn white. And so everything else is dark. So if we have a woman with dense breasts and we do a mammogram with contrast and her breasts are all dark, she doesn't have anything in all those white splotches or all that density.
Wonderful.
So yes, that's how contrast enhanced works, and it's a wonderful tool for us.
And a really important thing I think for women to also know is that just because your mammogram's normal, if you feel a lump, that lump's not okay. So we hear women come in and they say, well, I had this lump, or I had a skin change, or I had a puckering, or I had nipple discharge. I had some sign that I was kind of worried about, but when the mammogram was normal, I was reassured, so I didn't follow through with it. You know, and then you pick it up another 12 months or another 24 months later. So especially for women with dense breast tissue, if that woman notices a breast change, please, you know, pursue that and don't drop that just because your mammogram's read as normal.
Great advice, and we're going to talk more about self-breast exam when we come back. Breast cancer is nothing that anyone plans for. A diagnosis is shocking. Karin Burdick shares her story of diagnosis and how support from her family is helping her through the process of treatment and healing.
I am a mother of a 10-year-old son and an 8-year-old son. I am also a graduate student at SDSU, where I teach.
My name's Burdick. I'm a firefighter for the city of Sioux Falls. I own Pioneer Patio and Spa in Brookings, and I own a production company where we actually build haunted houses.
We're very busy, extremely busy. Yep, busy. In January of 2015, I rolled over to reach something on my nightstand, and I think something itched possibly, I can't even remember, but there was a lump, and I'm like, oh, that doesn't feel like it's supposed to be there. And I hadn't ever noticed it before, and I'd always given myself regular breast exams. So the next morning I woke up right away and I called my physician. He did an ultrasound on it and he looked at it and he said, nothing to worry about. There's no family history, it's probably just a fibrous tumor because that's common at your age. Come back in 6 months when you're 40 and we will do your mammogram and everything else. Dr. Jana Johnson was amazing because she touched that spot. I pointed it out to her and I said, you know, I also have a lump right here. She touched it and she literally jumped back and she goes, whoa. You need to get this checked. And I thought, I have been getting it checked. So the diagnostic mammogram was performed in town here. Dr. Jepson came and read the mammogram and did the ultrasound, and he then ordered a biopsy because it was not a cyst. I just purchased new bikes for my boys and we were gonna go on a bike ride and my phone rang. I have been diagnosed with invasive ductal carcinoma, triple positive breast cancer.
I knew immediately, just by the look on Karen's face, that it wasn't good.
All I thought about was my kids and my husband. Dr. Julie Reiland was the surgeon that we met with first.
She walked in the room and we had no idea what was going on, and she said, well, the team got together. And I said, what team? And as soon as I heard that, that just blew me away, and I thought, wow, Karin has a team.
At that appointment, she had said, this is your treatment plan, which would be 6 rounds of chemotherapy and then surgery. people just from everywhere coming out of the woodwork. And some of these people have sent charms, and I hadn't seen them for 20 plus years. My gratitude for their generosity and their love and their support. I mean, every single one of these beads has a story about our relationship, and it's just empowering. So many good things come from cancer. Things that used to be important, they just dribble to the wayside. I mean, it's just, cancer is, it's pretty amazing. It really is.
All the members of Sioux Falls Fire, they're always very compassionate, and they always go out of their way to make someone feel a little bit special. But I've always been removed from it. And I've always been able to show up, take care of the problem, move on. I've always tried to help people above and beyond any way that I can. But now I look at people differently because I know what they're going through. In the last 2 months, I can think of probably a dozen people I've been on. I've stopped and I've spent an extra 5-10 minutes with them just because I know they need to know that there's somebody that cares, that we're there for them. It's made me a better firefighter.
It's unfortunate you have to go through something that's devastating to realize how blessed you really are and how amazing your life truly is. I just want everybody to make sure that you're staying on top of your health. Know what's different. Do your breast exams. I mean, pay attention to your whole body. You know when something's wrong.
So the answer to our Prairie Doc quiz question tonight, among women who have health insurance, 72% had a mammogram in the last 2 years. Among those who do not have insurance, the rate is A, 22%, B, 39%, C, 44%, or D, 53%. And the answer is B, 39%. It was Connie McMahon from Piedmont who answered the question correctly. Thank you, Connie, for participating, and a book will be in the mail to you soon. So we wanted to talk about self-breast exams a little bit, especially after hearing that story that we just did. So Dr. Reiland, tell me your advice for women with self-breast exam.
I get a lot of that, and because women come to me with a breast lump, perhaps, and they just don't know what a lot of women will say, well, I don't feel my breast because I don't know what I'm feeling for. And that's really silly, because this is your body, and we just need to figure this out. So what I tell everyone, there's some great diagrams on how to do it, and the American Cancer Society has some, but I really like to make it easy, really easy, because if my patients have to do all of this with their hands, and they just go, I can't do that. Yeah. So let's just really make it easy. When you're lying in bed at night with your arm over your head, can I do this on?
Go for it. Absolutely.
With your hand like this, not the tips of your fingers, because in the tips of your fingers you're going to feel every little lump in your breast.
Okay.
And those are normal. You push down, all the way down to your chest wall.
Like with the pad of your hand?
With this part right here. See that? Okay, and it should all flatten out. Breast tissue is fatty tissue. It squishes out.
Okay.
And so it will all flatten. If you have something that's not normal, you'll be able to feel it under your hands. You'll go, wait a minute, that didn't squish out. That didn't flatten like it was supposed to.
Ridge. Yeah.
So.
Okay.
I carry this in my pocket. Can you guys see this?
It's like a little green stone.
This is a little green stone, and it is exactly 1 centimeter.
Okay.
A centimeter is the size of the size that we can feel a cancer.
Okay.
So if you had, and it's really not very big. If you just look at I don't know how, it's about the size of a pea. But the thing is a pea is round.
Can you hold that up again?
You see that?
There we go.
Oh, there we go.
There you go.
A pea is round. This is jagged and irregular. When breast cancer grows, it grows into the tissue and it invades into the tissue. It doesn't grow like a round ball.
Okay.
It grows like a jagged, irregular.
Like a rock.
Like a rock, and it's hard as a rock.
Okay.
So when you put your hand and you push your breast down to your skin, down to your chest wall, that rock is going to poke you back.
So when Karin said it was shocking to her when she felt it, that's...
Yes. And it was. It did feel shocking. So that's what I'm looking for when I do breast exams, and I do them on myself. And I'm always saying, okay, they're good. And it takes 5 minutes. But it's better than doing nothing. And so if you did that once a month, if you're still having periods, about a week after your period, or if you're not having periods anymore, just do it the first month, the first day of every month, and you just do that arm up over your head when you're lying down. For some women, when they're in the shower, they say, I do it when I'm in the shower. The problem is that under your breast, you can't get to under the breasts, especially if we're getting droopy as we get older. And so you can't feel that as well, and that's where some of those cancers can be, and you'll miss them. So do it when you're lying down.
It's great advice. We have a 62-year-old from Sioux City wondering about the role of diet and exercise in reducing her chance of getting breast cancer. So I know this is something you're both passionate about, so tell me about prevention with diet and exercise.
Go ahead.
So we know that for women who are at risk for getting breast cancer, if they can reduce their weight, they can, and exercise, they can actually reduce their risks by up to 40%.
Wow.
So if you're, we run risk models on people who are at risk, and we say, okay, you have a 30% chance of developing breast cancer, which is much greater than the 12% of the average population. You start dieting and lose that extra pounds that you have, and you exercise, and the exercise can be 30 minutes of walking, as little as walking, 5 days a week. That's all you have to do. And the studies show that you can reduce those risks from 30% to 18%. So I'm doing the math in my head. So that's remarkable. And when a woman has breast cancer and she's finished her treatment, we know that when they diet and lose weight, if they're overweight, or if they keep their weight at their normal BMI, body mass index, and if they exercise regularly, we know those women who diet and exercise actually have a reduced rate of breast cancer recurrence. So after you've had your surgery, your radiation, your chemotherapy, there's actually something that women can do for themselves to reduce their chances of having that breast cancer come back, which is why my sister is such a great foodie and
bike like 1,000 miles.
Right, because that is the one thing she can do for herself. And so for women who feel that they're at risk, look in the mirror. If you've got some extra pounds and you want to know what to do about it and how you can reduce your chances of getting breast cancer, lose those pounds.
Diet and exercise.
Yes.
So I think another thing for breast cancer survivors that they should realize is that it's often a little bit harder after you've gone through your breast cancer treatment to maintain that weight. And so what I always tell patients is look at your weight on the day that you're diagnosed and at least try to maintain that, because the average breast cancer survivor is going to gain about 20 pounds in the first year. Chemotherapy, carb cravings, steroids, not being able to be as active. So there are hormonal shifts, becoming postmenopausal. So there's so many different factors. But when we write down, I write down everybody's assignments. Everybody knows I have these famous, I constantly am scribbling. But we talk about chemo, we talk about pills, but number one on that list is always you shall exercise 20 to 30 minutes a day. And one of the key reasons isn't just emotional health and well-being, but a lot of women are going on the aromatase inhibitor pills. You can get some joint stiffness on those, and we know that yoga and activity and exercise improves your ability to tolerate your treatments. So that's another really important thing for survivors to know, is they have better odds of completing their treatment too with the exercise.
So I want to get at least one more question in before we're out of time. We have a 37-year-old woman from Brookings who's wondering about early diagnosis, radiation, hysterectomy. She's been doing well on tamoxifen for 5 years. The doctor says to take it for an additional 5 years. Any thoughts?
So there, I'd have to see her in a consult because it's kind of a complicated question. But the question is, should I do prolonged endocrine therapy? So for a lot of years, 5 years, standard of care. But we know that in hormone-fed cancers, half of the recurrence is in the first 5 years and half is in the second 5 years. So overall, 2 trials, huge trials, showed that 10 years of tamoxifen was better than 5. And that benefit was an absolute benefit of about 3%. So if you have positive nodes in a big tumor, that's going to be a bigger benefit. If you had a small, less aggressive cancer, maybe you don't need the 10 years. So when my patients get to that 5-year mark, we sit down for about 30 minutes and actually have a discussion, because it's an individualized risk versus benefit.
So come in and see your doctor.
Or talk to their oncologist about what are the pros and cons.
Well, thank you both for being here tonight. You've done a great job, and we'll be right back.
My mom was diagnosed with breast cancer at age 38. So she tested positive for Brca2. And then 2 years after that, my mom's younger sister was diagnosed with breast cancer. My family history of cancer was the main driving factor to pursue my PhD and to help others, and in the process, help myself. I tested positive when I was 25. It's been an emotional journey, but a good journey.
Dr. Mary Helen Harris, MD, was a college friend. We worked together on student union committees, and I grew to appreciate her musical talent, her 4.0 grade average, and her ways of supporting others around her. She was accepted into the medical school class 1 year after me, and we had been friends ever since. I took care of her mom and dad living in nearby Volga, but after they were gone, I still touched base with Mary Helen every once in a while. Dr. Harris discovered she had spread to lymph node breast cancer maybe 15 years ago. And after a significant struggle through the years, despite all the best care, she passed away this last week, leaving saddened family and friends. The most common cancer in women starts in the breast and affects about 12% of all women in their lifetime. It's more common in developed countries because of available screening and longevity. The Egyptians thought breast cancer occurred as divine punishment for some bad deed. And the Greeks thought it was a buildup of too much black bile. By the 1700s, people thought breast cancer came from too little or too much sex, too little or too much breastfeeding, breast infections, restrictive clothing, and even from the act of fearing cancer. Now, although we know risk factors, we recognize that we don't know why anyone gets breast or any cancer. By the late 1800s, people were living longer, and since risk increases with age, breast cancer was on the rise. Surgeons began to radically excise cancerous breasts along with adjacent muscle and lymph tissue, which raised the survival rate from 10% up to 50%. Although more breast cancer patients survived with radical surgery, often they suffered with lymph-swollen, painful arms. Presently, breast-sparing surgery is done where just the lump and only a few lymph nodes are removed, resulting in much less arm edema. And with the advent of safe breast implants, chest deformity is not such a problem. Along with these innovations in surgery have come advancements in screening and better treatments in radiation, hormone, and chemotherapy with incredible improvements in survival. Now, many more women with breast cancer are alive at 5 years. And when caught early enough, the lifespan of those with breast cancer are the same as those without. Still, cancer can kill despite all the best care anywhere. And I believe my doctor friend Mary Helen had all that best care. I regret I didn't have the chance to touch base with her one more time.
A big thank you to our guests, Dr. Amy Krie and Dr. Julie Reiland, for being here tonight, both from Avera. We sincerely appreciate your willingness to volunteer and be on this program. That does it for us tonight. Have a great evening. Hello and welcome to On Call with the Prairie Doc After Hours. We've had many great questions submitted beyond what we could answer tonight during the broadcast portion of the show, so let's get started with those. So our first question is from a woman who's wondering if she should have a surgeon remove her breast lump or if she should have a needle biopsy. Dr. Reiland?
Okay.
Go ahead.
Yeah, so this, I'm assuming this patient was probably just found maybe to have an abnormality on her mammogram. What will usually happen then is that woman will be called back in for diagnostic imaging. Okay. So when you get diagnostic imaging, then they're doing a mammogram and they're seeing if they can find the spot under an ultrasound to see if it's solid. The standard of care is absolutely for her to get the needle biopsy. Okay. So excisional biopsies should only be done, and Julie can correct me, but there are a few occasions that we have to do an excisional biopsy if something is deep, deep down on the chest, or if something's right under the skin. The radiologist may say, I can't safely get to this. But at our institution, less than 5% of the biopsies are ever done that way. The problem, so we would recommend the core biopsy done by a radiologist. Okay. And if their community doesn't do that, they should really seek out somewhere that could be done. The problem with what they call the excisional biopsy, or the surgeon taking you to the operating room just to see what's on the mammogram, is some things aren't cancers, so that woman's going to have a larger scar and a surgery on what isn't even a cancer. And then B, a lot of times, for instance, some of my research options, Dr. Reiland's surgical options with the radiation therapy and putting the scars in nice places. A lot of times if they've already had that lump removed, it's very hard for us to then make the breast look nice, give them options for less radiation. So one should really never have an open excisional biopsy by a surgeon unless they've gotten a second opinion really saying that's all they can have.
Anything to add?
I agree.
I do okay on that one.
You did great. and the thing is that we need to keep that breast cancer in there if it's a cancer, and because some of those women may benefit from chemotherapy. And if we take it out and throw it in the bucket, then we don't know if that chemotherapy works. And watching that cancer shrink because we're giving them the right drugs is so gratifying to the patient, to us. Plus, it tells us this cancer is going to be, we know how to manage it because we're seeing it shrink. When they don't shrink, we say, okay, we got to change the plan. So knowing that information is so beneficial, especially in these breast cancers that are more aggressive. And so that's why you can't take them out. Hang on. Don't just take it because you want to, but you have to leave them in there so we can do the right things.
And I also think, for the patient, it's literally 2 surgeries. So it's more expensive, it's 2 anesthesias,
it's
2 recoveries. So
second chance for an infection. When you have to go back in and it's already been opened, then I worry a little bit more about infection as well. So lots more complications.
And cosmetically too, I think sometimes it's really challenging. So yeah, that woman should definitely, unless that's simply the only option, she should get another opinion on that.
We also have a patient who's wondering, they're diagnosed with stage 3 or 4 breast cancer. Is there a time when you don't recommend treatment? When you recommend more herbal things or more natural things and not chemotherapy, surgery?
The issue is that, especially for stage 1, 2, and 3 cancer, these are curable situations. So that woman typically with the appropriate treatment can go on to lead long, healthy lives. And I think the idea of just doing supplements or something naturopathic is that they think it's sort of more natural. There's no side effects. Any of us would rather do that. But unfortunately, even some of our doctors who practice integrative medicine, so they're both MDs and herbalists trained, they'll tell you they don't have anything that cures cancer. Where I use acupuncture, supplements, integrative medicine is definitely complementary to what we're all doing together. So we actually have that department in our cancer center. And just this morning, 2 of the patients who got chemo did acupuncture beforehand because it really helps us with nausea and their energy level. So it's complementary. It does help minimize side effects, but we're not at that point where it's a curative treatment. And unfortunately, we've seen situations where sometimes the patient will come to us with a very curable cancer, say, no, I'm just going to do a certain supplement that they heard about in Mexico or on the internet or something, and then 4 years later we're seeing them with cancer kind of spread through their body. And we've both lost patients in that situation, so I think it's kind of near and dear to our hearts that people really think twice. They can do both, but unfortunately we're trying to cure people. So I would stick with mainstream and what's been definitely proven.
Anything to add to that, Dr. Reiland?
She's got it.
I just wanted to read a last comment from one of your patients. It said, Dr. Reiland and Dr. Krie were my doctors for surgery and follow-up nearly 6 years ago. Thank you for your professional help in prolonging my life. So,
Oh, that's wonderful. Yay.
I bet that feels good when you see those success stories come back in.
It is. I want, we all watch it. We both watch our patients for 5 years, sometimes longer. It depends upon what their issues are. But I love having them come back. It's wonderful to see them because their cancer's gone. Crisis is over. They've now gotten back to their regular life, and we get to be a part of that too. And
I'm always
that's
like,
always
5
fun.
years. We can't be 5 years older. We don't
No,
look
I
5 years
know.
older. I know.
Well, you are a wonderful, caring, and compassionate team. So
Thank
thank
you.
you for everything tonight. Thank you for joining our website. We appreciate all of your questions and the opportunity to answer them. And until next time, with all of us from On Call with the Prairie Doc, stay healthy.
Sexuality, especially as we get older, impacts our lives. During sex, endorphins are released that improve our lives in many unexpected ways. Sexual health at any age. Next time, On Call with the Prairie Doc.
Funding for On Call with the Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, an organization working with the state's healthcare community to improve quality of care as part of the Great Plains Quality Innovation Network. Additional funding is provided by Aberdeen Asthma and Allergy, Avera Heart Hospital, Brookings Health System, Dakota Allergy and Asthma, Dakota Care, Orthopedic Institute, Physicians Care, Sanford Clinic Community Service Committee, South Dakota State Medical Association, Swiftel Communications, and Vance Thompson Vision. Closed captioning for On Call with the Prairie Doc is provided by Avera, Brookings Health System, and Fishback Financial Corporation.